I'm sure you'll have a lot of questions for Jeanette in the Q&A period. So our next speaker is Dr. Nyame, who's in the Department of Urology. He's a urologist. There's much to learn from understanding why certain groups or populations are disproportionately affected with prostate cancer in terms of either its incidence or aggressive behavior. So you're going to hear a bit about that this morning.
All right. Good morning. Thank you for giving me the opportunity to speak with you today. I'd like to start the talk with a simple definition for health disparities, which simply could be a difference in health outcomes or healthcare services between population groups. And I think a really good example of that can be seen in this map of the United States from 2014. So this is a county level map of the U.S., and the areas that are in darker red, which my wife tells me this dark red, I'm colorblind, this is the southeast U.S., and these are places that have higher rates of death attributed to prostate cancer in 2014. And the areas that are in the darker blue are areas where there are lower rates. And so this is a very nice and simple example of disparities by county level. On this talk, I'm going to focus on disparities by race and ethnicity because I think that's a very prominent difference that we have in the United States. But you can, as you can imagine, if you're comparing different populations, you may see differences in outcomes by a varying degree of factors. In the United States, when we look at the number of new cases that are diagnosed each year, this is a graph that shows a 4-decade time span of new cases, and it's been pretty consistent that black men in the United States have had more new cases of prostate cancer diagnosed compared to men of other races. And that stayed consistent even with the introduction of PSA screening in the late 80s, early 90s, which has actually led to less new cases being diagnosed. Perhaps even more troubling is when we look at deaths attributed to prostate cancer, we see a more than 2-fold higher risk of mortality in African American men. And again, that has stayed pretty consistent even with decreases in mortality after the introduction of screening, which was discussed by Dr. Nelson. So what are the drivers of health disparities? And I think one of the things that most folks that are in the public health space talk about are the social determinants of health. And these vary from economic stability, the neighborhood and the physical environment that one lives in, the education status, food sources, the community and social context that someone lives in, and the healthcare systems that are available. And I think we can all envision how any one of these factors can influence the value that we place on our health state and the decisions that we can make about how we receive health care. And this Anderson behavioral model, which was developed at UCLA in the 70s, gives a nice framework for integrating the different social determinants of health. So starting on the far left with the predisposing factors, age, gender, race, underlying genetics, those are going to influence how we utilize health care. You have to have enabling factors such as education, insurance status, income that enable you to interact with the healthcare system that you're in. There has to be a need. And so, for instance, a competing comorbidity might actually lead you to a diagnosis of prostate cancer. So you go to see the urologist because you have difficulty urinating and get a PSA. There has to be a context in which you practice, or receive care, excuse me. And so for that, the density, how many physicians are in the group. I always talk about this. In Ghana, where my family is from, there are 7 urologists, or at least that's the last count I got. There are 7 urologists. There are more than 7 urologists in the department at the University of Washington. And so, but you can understand how that can impact your ability to receive care. And ultimately, all these things factor in together to have an impact on how you require care, whether it's clinic visits, whether it's radiation or surgery therapy, or even getting surveyed for your disease. And I think can't have a discussion about disparities without understanding the difference between equality and equity. So equality is giving everybody the same thing. And I think when we talk about policy for things like prostate cancer, and we think at a higher level of how we can improve care for everyone, the simplest solution is to give everybody the same thing. But as you can see from this illustration, the youngest kid on the right is getting the same thing as the other folks, but he can't see that soccer game. Right? So, but for equity, is to give people what they need to achieve the same goal. And so in the illustration on the right, what we see is that the kid who can see over the fence without the box is giving up his box to the kid on the far right who can now see the game. And all three are getting an equal outcome. So using the Anderson behavioral model, we've come up with our own view of how prostate cancer care is delivered. And in the interest of time, I'm going to go through this quickly, but I'd be happy to speak with anyone during the break about this model. And what we have are predisposing factors, such as family history or race, ethnicity, which probably likely reflect genetics, impacting in concert the risk for developing cancer, in concert with environmental exposure such as smoking, diet, environmental stress. And carcinogenesis is a fancy term for the development of a cancer. And between carcinogenesis and the presentation of symptoms is probably one of the first really important time points in receiving care, which is screening for prostate cancer. And you can imagine that screening could vary quite a bit based off of your social factors and the healthcare factors that are around you. Do you have access to a primary care physician who can check a PSA? Do you have access to your urologist that can then take you to that biopsy to ultimately be diagnosed? Whether you have symptoms or screening leading to your diagnosis, you then can progress to two arms. We have localized disease, and then we have metastatic disease. In the localized disease frame, I think this is a rapidly evolving paradigm in which we've gone away from a one-size-fits-all treatment strategy. And so you can imagine, again, the access that you have to care, the things such as diet and exercise and supplements, how can they modify your risk, what are your own preferences for treatment, can all impact the way that you interact with this top portion of this flowchart. And once you receive therapy, whether you receive surveillance, if you progress, the ability to have access to salvage therapies, again, can all be affected by the different social determinants that we talked about. And then on the bottom portion of this flowchart, you have metastatic disease, where the mainstay of treatment is still systemic therapy. But if you think about systemic therapies in the current environment that we're practicing in, we've had a lot of changes. In the last 3 to 5 years, we've had high quality data that suggests that Lupron or some form of androgen deprivation alone is not sufficient. And a lot of these medications that are coming in that are prolonging survival in patients with metastatic disease are, quite frankly, very expensive. And so you can imagine an environment in which the introduction of beneficial therapies may actually exacerbate disparities by not being available to everyone. And then on top of all of that is survivorship, which is very important. As many of you in the room know, living with your disease can impact a lot of the social factors and a lot of social determinants that I had pointed out. So very quickly, is there underlying biology for prostate cancer disparities? Well, I love this map because it shows how different people are genetically. So these are black men in the United States who have had a genetic test for the amount of African ancestry that they have. The gray states simply didn't have enough information for the test. But what you see is someone who's in the southeast United States, where we saw some of the highest rates of prostate cancer mortality in that first graph I showed, have higher areas of African ancestry, well, compared to, let's say, the West Coast or the Pacific Northwest. And so genetically even, we see differences that may impact prostate cancer risk. This study from Detroit is an important one because they took tumors from patients who had had prostatectomies, and they tried to assess whether or not their biology was different. And I love this chart for two reasons. One, it does tell us something of import. In blue here are African American men, and in yellow, are men of European ancestry, and we see that they have very different networks as far as the molecular biology of their tumors. However, the other thing that this points out is how complicated it is, because this flowchart has arrows that go between a lot of different factors biologically. And so I think despite evidence suggesting that there is some difference in biology, it is important to understand that we are in the infancy of understanding this relationship. And perhaps more important than the biology may be how patients are receiving care. So what are some of the drivers of treatment choice? I like this study that just was published out of Boston that shows that the majority of African American and Latinx patients are getting their care in what are called minority serving hospitals. So these are facilities that predominantly take care of underrepresented minority populations. In the study, they found that they had a 25% decrease odds of receiving definitive therapies such as surgery or radiation in patients who had intermediate or higher risk disease. And there were some delays in care in this study in that population. The delays are probably not important, but what I think this reflects is the type of facilities that the patient population is receiving care at. And those are likely to be safety net type facilities that are in some way resource poor. And so this isn't an indictment on the quality of care that's received there, but it does tell you a little bit about the demographic that's receiving care at these types of institutions, and what decision making that's happening there could have on outcomes ultimately. The other piece of the conversation I think is important to remember is that patients have preferences for care. And so this study from North Carolina, I think, very nicely demonstrates within North Carolina, this population, that there are differences in education status between patients that can inform their decision making, that there are different priorities for the type of care that's received. So African American men in this North Carolina cohort were twice as likely to factor the time that their treatment would take and the recovery time in their decision making for treatment. And men in this cohort also underestimated the severity of their disease. And so perhaps there is an opportunity to not only factor in the preferences with regards to treatment type as far as length of treatment, but there's also an opportunity for us to better educate patients about the treatments that they're going to receive and the severity of their disease, and doing that in a way that can get communicated clearly and maybe in a culturally appropriate way. So I just wanted to end with some ongoing projects that have started here at the Fred Hutch between myself and some of my collaborators here. And so we have recently received funding from the Department of Defense to try and look along that continuum of care that I showed, to identify areas in which we could better serve patients to decrease disparities along racial and ethnic lines. And that's really focused on healthcare delivery models. And I'll be doing that with Dr. Ruth Etzioni and John Gore, who will be our next speaker. Dr. Gore has actually disseminated a prostate cancer survey, which is aimed at getting information directly from patients about their experience with prostate cancer. He's going to be speaking about that, and so I won't spend too much time. But one of the things that I'm really excited about in this effort is that we are partnering with the Prostate Health Education Network, which is an advocacy group for African American men. And so we have an opportunity to increase the diversity of our responses in this effort. And I think that could give us really good insight into what patients need from us. And then lastly, we're doing some work in the genomic space to try and add to the body of literature with regards to the biology and the biologic differences, I should say, of prostate cancer along racial and ethnic lines. So with that, thank you very much for your time.
Wonderful. So quality of care, treatment outcomes, and side effects are critical parameters of how we think about prostate cancer. The Men's Health Clinic at the University of Washington is very involved in this, and as I mentioned, there'll be a table at lunch